Thank you for your kind introduction. First of all, congratulations on great success of BLC 2026. It's my great honor to give a small talk to you. Actually, I guess I'm the only radiologist in this room, so that's why I'm not sure how much of you are interested in my topic. Please enjoy. This is just a single video. There's no table. Okay, the title is Minimizing Risk of Local Regional Therapy. How can we achieve the complete treatment while keeping the safe? Our goal is to balance two sometimes competing values. So I'd like to introduce some minimizing the risk in local regional therapy for liver tumor. I'd like to summarize the three key characters: selection, prevention, and management. This talk is not about a new device or a new technology, decision-making details, and discipline in daily practice. This is my ablation feasibility map. Maybe all of you have this kind of concept in your practice. A complete ablation achieved by excessive or inaccurate treatment can be dangerous. So the real challenge is not choosing safety or completeness. It is a right balance between the two. This balance actually begins long before you turn on the generator. SPM, my approach to risk minimization. Selection, prevention, and management. Most major complications, as we all know, can be avoided by good selection. Many others can be prevented by careful prevention. Mortality also always be avoided by early detection and proper management. Let me start with the first, selection. As we all know, the many international guidelines mentioned about the risk minimizing concept, from EASL to Asian guidelines. We will notice one common theme: risk minimization starts with best selection. Recently, Korean guideline and Chinese guideline also emphasized the importance of patient selection and pre-procedural assessment and tumor location relative to vital structures and structured follow-up strategy for delayed complication. Across the international guidelines, risk minimization centers on strict indication criteria to structured post-procedural monitoring to detect delayed complication after ablation. As you know well, the most international guidelines agree on the criteria on safety: first, liver function, bleeding tendency, tumor size and number, and assistant supportive technique for the safe ablation. However, the reality is quite different in our practice. There are so many things matters for safe ablation: tumor shape, tumor aggressiveness, tumor marker, tumor conspicuous and guiding modality, application path, perivascular, periductal or peri-organ proximity, biliary dilatation, post-op adhesion, anesthesia assistance, and comorbidity and economic status, operator experience, available energy source. Very complex scenario. It is hard to prove on our clinical study. So I would say devils in the details. Most complication rate in the literature is sometimes meaningless. What about my contraindication for ablation? I think it is quite similar to yours. I don't do ablation if the tumor size is larger than 4 centimeter or smaller than 1 centimeter, and 3 or more tumors, poorly visible tumor, even after fusion or contrast lens ultrasound, and aborted to main IHD and both main portal vein, and tumor is too exophytic, and significant coagulopathy, and artificial ascites refractory perihepatic adhesion, especially to colon and duodenum and diaphragm, and also alternative method remains. This is not weakness, this is risk management. Multidisciplinary approach is the really smart key for successful and safe ablation. It allows us to balance safety and oncology effectiveness. Personalized decision reduce unnecessary risk. What about the prevention? If I decided to ablate, my mindset is totally changing to achieve safe ablation. Every procedure carries potential risk. I do everything possible to prevent any complication. For example, I always do planning ultrasound before a procedure. Definitely should correct coagulopathy and use artificial ascites or refusion, and administer antibiotics for the patient with biliary dilatation, and use fusion and contrast lens ultrasound for accurate and continuous monitoring. And during the ablation, I should do the careful insertion of the applicator as much as I can. I don't start any ablation if I cannot see the electrode tip clearly, and always close monitoring during the whole procedure with ultrasound and ablation zone compared to my planned ablation zone. What about artificial ascites? This is a representative protective method, not just a technique, it is a safety philosophy. It creates space in the abdomen and improves visualization and protect adjacent organ, as you know. So this is a short video, please enjoy.
The first case is microwave ablation with artificial ascites. The patient was referred to ablation before colon cancer surgery. For preparation of artificial ascites, we use 5% liquid solution and 5% engine introducer sheets rather than spinal needle. The tumor was barely seen even after fusion imaging application. After skin and peritoneal anesthesia, we insert 18-gauge angiopuncture needle just at the subcapsular portion in the state of breathing state. And we instruct the patient to fully breathe out. At this time, the tip of needle sheath is retracted from the hepatic capsule and is usually placed into the perihepatic peritoneal space. We quickly insert guide wire through the sheath and replace it with 5-French sheath over the guide wire. Now we can repeatedly infuse the fluid through the 5-French sheath. Usually we use 300 to 1000 milliliter in most cases. In most cases, the sonic window is significantly improved by downward displacement of the liver in a few minutes. the probability for accurate placement will be definitely increased. Now, it is time for insertion. Actually, most critical part of any type of needle ablation. After insertion at the planned site, we often use CEUS for final checking the really accurate placement of the applicator. Just before starting ablation, we set 2 circular markers for monitoring whether we achieve a sufficient and circumferential ablative margin. During the ablation, we are closely monitoring until the hyperechoic ablation zone finally occupies this red circle.
예, 휴식되었다가 열을 붙여드립니다.
Okay, I do anything to prevent potential complication risk. For example, stepwise increased power to prevent popping phenomenon resulting in transporter spread and peritoneal seeding. And also I use the Sonazoid contrast enhanced material to minimize the popping phenomenon based on our studies. And also, if I feel the excessive ablation zone along a lot of micro bubble in the peripheral segmental portal vein, I usually stop the ablation or decrease the power. It can make the significant portal vein thrombosis. And also, if the patient vital sign is unstable and complain of severe pain and consider the stop and decrease the power, unnecessary overlapping ablation should be avoided. Excessive ablation is the most common cause of major complication. Final management. What truly determines the outcome is early detection and proper management of any kind of complication. If you detect any complication and properly manage it according to the planned management, including transfusion, embolization, and PCD, and even surgical resection. This is very important to avoid any mortality after this kind of a minimally invasive treatment. So you should understand really broad spectrum of complication after ablation. As you know, among them, the 3 important complications, bleeding, infection, thermal injury, are the most common and important complications which can result in the mortality. We should remember, if you miss this complication early time, you can lose the patient. Be it bleeding, infection, and thermal injury. Let me summarize my talk. Major complications can be avoided by careful selection. Many more complications arise from inaccurate and excessive ablation to achieve just complete ablation with sufficient ablative margin. Mortality should be avoided by early detection and proper management of any complication after ablation. Thank you for your attention.